Hello, my name is Daniel Noller, and I will be the reporting nurse for this assignment today. The patient today is an 83-year-old woman who has been widowed for the last 18 years. In her early adulthood, she worked as a school teacher for 10 years before leaving the workforce and becoming a housewife to raise her family. She does not have a formal job in the last 50 years. She's been retired for the last 18 years, and her primary source for health services is her primary care physician. Her chief complaints today include numbness in her lower extremities, primarily in her feet, and chest pain. Her health history includes illnesses such as arrhythmia, which she's had since birth, hypertension since 1988, arteriosclerosis since 1988, ventricular tachycardia since 2002, congestive heart failure since 2002, pulmonary fibrosis in 2005, and then osteoarthritis since the 1980s. She's only had the annual flu vaccine and the pneumonia vaccine, no other forms of immunizations. She has seasonal allergies and allergies to morphine and other forms of anesthesia. For surgery, she's had a double coronary artery bypass in 2002, a pacemaker and defibrillator transplant in 2002, 2 cardiac ablations from 2011-2012, 4 heart stents from 2004-2012. For medication, she takes levetiracetam, androderol, aspirin, Allegra, Lasix, Zacor, Spirea, and a potassium and calcium supplement. She does not drink alcohol since 1999. She has never smoked. She does daily leg exercises and arm exercises, including stretches that exert her muscles in her lower and upper extremities, daily walks around her house and yard and farm, and then she lifts 5-pound weights. She does these activities daily. She sleeps around 6 hours a night and wakes up an average at 6 a.m. Her diet includes no green vegetables due to complications with the medication, beans, cannot eat any citrus fruits, does however eat peaches, grapes, apples, etc. She does not eat any junk food, minimizes red meats, and watches fluid intake. She drinks decaf coffee with no other forms of soda or caffeine. She does not use any safety devices. She has a family of 2 children and 1 grandchild. Her extended family is all but deceased at this point. She has an independent lifestyle, is able to drive by herself, able to do household tasks such as laundry, cleaning, cooking by herself, and she's happy with her life and is optimistic about her health. She's a practicing Lutheran, has a bachelor's in education, and has a family health history of asthma, cardiovascular disease, seasonal allergies, with no neurological or cognitive disorders. Today she feels good with no drastic changes. Some days are worse than others, with experienced symptoms such as shortness of breath, lower extremity pain, chest pain, and fatigue. In the last 2 years, she reports going in and out of heart failure, during which she experiences respiratory changes, fatigue, loss of appetite, and activity inhibition. On general days, she's able to perform her activities of daily living. On bad days, she reports feeling fatigue and tiredness during activities. She believes that heart failure is the cause of this problem. She's had this problem since 2002. She's gone to doctors who have given her medication, diets, and exercise plans to help her manage with these symptoms. Because of them, she's able to respect her body's ability and be able to live as she wants. She's had a family history of cardiovascular disease, such as her father, who had 2 heart attacks, one in his 50s and one in his 60s. This died after the second one. And her son has hypertension and is given a blood pressure medication to deal with this. She has a weight of 120. Her weight can alternate up or down 5 pounds per week, as she does not monitor her fluid intake and doesn't notice this occurring. She notifies her doctor immediately about it. She's had arrhythmia her entire life, but was not diagnosed until after her first heart attack in 2002. She was diagnosed with congestive heart failure in 2002 and has had a variety of surgeries, procedures, medication, with diets and life routines, all of which have been very beneficial to her. She's never had a cardiovascular infection. She's had a defibrillator and a pacemaker implanted. She's had hypertension in the years prior to her heart attack, but no longer suffers from it. She has hypothyroidism, and both her triglycerol and her cholesterol levels are below normal limits. During heart failure, she feels symptoms such as confusion, back pain, coughing, dizziness, fatigue. These symptoms do not change with position, and the pain in her chest feels like a knife turning in her chest. This pain does not radiate across her body. At the worst point, these symptoms were at a 10 out of 10, but they have not reached that point since her 2002 heart attack. Diet includes monitoring her fat, protein, carbohydrate intake, understands the difference between saturated and unsaturated fats. She does not use any flavor enhancers such as salts or sugar. She has never smoked, and she is not exposed to secondhand smoke, and she has never used recreational drugs. Reports having no cognitive or mental deterioration due to age. Medication has caused side effects such as stomach pain, rashes, and fatigue, with her pulmonary fibrosis being caused by an allergic reaction to a drug. Her review of symptoms begins with the cardiovascular system. Data onset is 1988, with a diagnosis of arteriosclerosis. Aggravating factors include poor diet, such as high cholesterol and fat intake, and a lack of exercise. Her alleviating factors include implementation of a proper diet that focuses on low cardiovascular, low calorie intake, and low sodium intake. She uses medication that related to her cholesterol and blood pressure, and she exercises daily. Her aggravating factors include family history of cardiovascular disease. Her course of problems, her condition remained stable in 2002 when she had her first heart attack, after which her health restabilized until it worsened again in 2012. Interferences with daily activities include shortness of breath, physical inhibition, fatigue. She's optimistic of her situation, and she feels independent and in control of her life. She has no signs of heaves or lifts in the 5 areas. She has no contour of the chest, no vibration in the first 4 areas of the heart, but she does have slight thrills on the apex and mitral areas of the heart. Mitral apex area of the heart is the PMI. Her pulmonic area has normal S2 sounds when auscultated. Her aortic area, however, has a grade 3 murmur. Her Erb's point is normal. Her mitral and tricuspid areas have weak S1 sounds when auscultated, and her mitral area has the presence of a grade 3 murmur. She has no presence of S3 or S4 sounds when auscultated. The date of onset for her perivascular system is her diagnosis of hypertension in 1988. Her aggravating factors include excess fluid intake, excess sodium intake. Her alleviating factors include implementation of diets that reduce her fluid intake, reduce her salt intake. Her precipitating factors include family history of perivascular disease, and her course of problems is similar to cardiovascular, remained stable until 2002 with her heart attack, then restabilized and worsened again in 2012. Symptoms include numbness, a sense of coldness in her lower extremities, pallor of the feet and legs, and pain in her lower extremities. Her perception is she's optimistic of her situation and feels independent and in control of her life. On an average day, she does not notice any changes in her skin color or consistency. However, during episodes of her heart failure, she notices pallor in her hands and feet. Her legs generally feel cool and average, and she generally has numbness in her legs, especially her feet. She has been diagnosed with hypertension and varicose veins. She has noticed a progressive change in her fingers, which has become more dry, cold, and again a lack of sensation. She has experienced swollen vessels in her calves and feet, with no other swelling in her body. She has no signs of ulcers or sores on her body, and she has noticed numbness in her feet and legs, and has no history of swollen glands in her body with occasional leg cramps. Her PVS findings include signs of varicosity, no signs of cyanosis, abnormal hair distribution, signs of edema, a 2+ centimeter with a +1 grade, no ulcers, pulses with temporal, which was bilaterally equal, regular and strong, grade of 2, carotid with the right side being weak in the left side, regular pulse and somewhat palpable with a grade of 2. Both the brachial and radial are strong, easily palpable, regular, grade of 2. Then the popliteal, posterior tibial, and dorsal pedis was weak, not easily palpable, but had a regular beat in a grade of 1. Her skin had signs of edema, grade of 1 once again, was cool to touch, and had signs of varicosity. The respiratory system. This is related to her health history, pulmonary fibrosis. The Secker et al. Article describes the assessment of the respiratory system, primarily the auscultation, as an effective and necessary procedure. These assessments are necessary to understand the nuances in symptoms and indicators of disease. According to the Noller et al. Article, this is especially true with pulmonary fibrosis because there are different forms of the condition. One form, idiopathic pulmonary fibrosis, or IPF, and which little is about the causes of IPF, but it has a high mortality rate, with most people dying 3 to 5 years after diagnosis. It is most common over people of the age of 70. The articles overall found the assessment of symptoms will enable the care team to effectively treat a patient. Musculoskeletal system. This is related to osteoarthritis, which inhibits her general mobility. According to the Schreibpins et al. Article, fatigue results from osteoarthritis and is a determinant to holistic health. It affects her emotional and physical well-being. Statistically, this condition can lead to mobility inhibition and unsteady gait, which increases the likelihood of a fall. According to the Rothman et al. Article, nursing assessments can indicate patient risk for elevated complications. One of these assessments that was found to be important as a risk indicator is a musculoskeletal assessment. Early detection and treatment of symptoms can minimize patient risk. Therefore, the implication of assessments such as the musculoskeletal system is vital in reducing patient health risk.